Especially that's what we were talking about earlier. Big man's here.
Oh, how are you?
Good.
Always good?
Yeah.
Good.
Place.
Great.
Yeah.
Fantastic.
No,
Andrea, we've been on the phone so many times.
Yes.
Nice to meet you too.
You too.
It's so good to see you. I feel like you're like our partner in crime or partner in, yeah, exactly.
All right, why don't we go ahead and get started? Let's begin today's event entitled Underage, Addressing Reproductive Health and HIV in Married Adolescents. My name is Sandeep Bathala, and I'm the Senior Program Associate for the Environmental Change and Security Program, as well as the Maternal Health Initiative here at the Woodrow Wilson Center. And today's event is part brought to you as part of our cooperative agreement with USAID's Office of Population and Reproductive Health. And with that generous support, we look at the various connections between health, population, livelihoods, environment, and security. I know that many of you have been here to the Wilson Center, which is the formal memorial to our 28th president, where we bring the worlds of policy, practice, and academia together. But did you know that we are the top think tank to watch in the U.S. and also voted one of the world's top 10 think tanks? So thank you for joining us today and ensuring that we do have that sort of ranking. Speaking of things to watch, our event is being webcasted live today. So what that means for those of you in the room, when we do come to the discussion, I'd ask that you use a mic, and my colleagues will be coming around with them. I'd also ask that you introduce yourself and affiliation. I also wanted to mention that the hashtag that we're using for the Twitter handle that we're using for today is #Reproductive Health. So if you'd like to join that discussion as well, feel free to. And if you need a Wi-Fi passcode, they're written on the side of the room. I want to direct your attention now to our speakers, but I do want to point out that it's not a coincidence that we're having this event about a week after the 20th International AIDS Conference. I know that there has been some particularly sad reasons that the mainstream media has known and commented on the conference, but for those of you who somehow aren't aware, the attendees there assessed where we are, evaluated scientific developments and lessons learned, and collectively charted a course forward when it comes to HIV/AIDS. We're also following the Girls Summit, which also recently just occurred, and that's where a real global movement was kickstarted to end child early forced marriage as well as female genital cutting for all girls within a generation. And I think at least 2 of our panelists were recently at the Girls Summit, if I'm not mistaken. You have access to more detailed bios if you didn't grab one on your way in. So I don't want to take from our precious discussion time going too much into folks' impressive histories. I will first introduce Elizabeth Berard, who actually has 2 titles. Technically, she's the health science specialist for USAID, but for the purposes, I think, of this panel, her second title really speaks to what she'll be speaking about. She's the youth advisor for USAID's Office of HIV and AIDS. So, Elizabeth, thank you.
Hi, good afternoon, everyone. Yes, USAID likes to keep us on our toes and give us various different titles, some of which we use in one context and others we used in another. So thanks so much for having me today, and thank you so much to the Woodrow Wilson Center for having us here today to talk about this important discussion, because I think there's a lot out there, and there's a lot to that we will be discussing in the coming hours. So when I was asked to do this presentation, I was really immediately interested, but I thought to myself, I don't really know if there's much out there on married adolescents living with HIV. And as I got into it and into some of the research, I discovered I was right. There's not much out there regarding married needs of adolescents living with HIV. I actually found about 1 paragraph. So I think there is a lot of information out there regarding the needs of married adolescents, and there is a lot out there regarding HIV and young women's increased risk of HIV. And every day there's more out there regarding adolescents living with HIV and their specific needs. But the ideas of married and adolescents living with HIV just didn't seem to intersect. And that's why we're here today, to talk about where these worlds collide. Many of you in the room can tell us significant stories, both from your lives and also from your careers, of where you have met married adolescents that have really blown you away. Some may have been stories regarding young women that come from villages where social norms encouraged early marriage. Others may have been told about a young woman that was married at the age of 13 to a man that was 30 years her senior. Others have told you stories regarding where a young married adolescent that might be 14 is immediately expected to have children. And beyond this, we know of stories of partner violence and young women having no place to go. In the context of young married adolescent girls, I did want to bring in young adolescent boys. And just to say that, you know, while there was some information out there regarding young married adolescent girls, there is next to no information out there regarding young adolescent boys. I came across one resource in my very, very scientific Google search. And this one resource was by Gary Barker from Instituto Pro Mundo and his colleagues from Instituto Papai from 2003. And I think the significant thing to mention is that while early marriage for boys is less common than for girls, between 2 and 24% of 20 to 24-year-old men are fathers. So I wanted to mention that. Do I go left? Okay, perfect. I want to segue into the world of adolescents and HIV. As many of you know, in 2010, roughly 42% of the new infections and people over the age of 15 were to adolescents young people aged 15 to 24. This means that a lot of both married and unmarried youth are living with HIV. This is especially challenging in that many individuals, most individuals in fact, don't know that they are living with HIV. And this is critical as early diagnosis can reduce disease progression and also allow us more effective care. It's challenging today to know how many people are living with HIV, or specifically how many adolescents are living with HIV. There are a variety of different numbers that are floating out there, some for 15 to 19 years old, some for 15 to 24-year-olds, others that are just somewhere in between. We hear numbers circulating between 2 and 5 million adolescents living with HIV. And the majority of these are in sub-Saharan Africa. While it's clear in some cases, many times it's really difficult to determine if a young person has been perinatally infected, and that is from the mother to the baby, or behaviorally infected, including sexual transmission, blood transmission, or intravenous drug use. In talking about perinatally infected and behaviorally infected adolescents living with HIV, I think it's important to understand that there are some similarities and some differences regarding the considerations and care for these adolescents living with HIV, and I wanted to highlight just a few. In terms of perinatally infected adolescents living with HIV, they may be more advanced stages of HIV and experience more complex obstacles for self-care. They also may have lost loved ones, such as parents and siblings. And additionally, unless HIV is truly hidden from the youth and sometimes from their families, they may not actually be forced into early marriage. In terms of behaviorally infected adolescents, they're in their earlier stages of treatment, and it may be less complex. They may be experiencing denial and fear of their diagnosis, and many times they have very different psychosocial needs. Many of these adolescents have been infected via coercion and abuse, whether as girls or boys, including young men who have sex with men. Some were raped, and others were abused by family members and friends. And I think that this is a really important consideration for behavioral transmission. Today, as more perinatally infected children transition into their adolescent years, we're learning more and more about HIV survival for those in treatment and those not on treatment. In 2009, Dr. Dr. Ferran and others published a study that revealed that over a third of children who were perinatally infected and not on treatment were slow progressors and were living to a median survival age of 16. Turning the table to adolescents infected later in life, one study from 2002 in rural Zimbabwe indicates that there's no difference in HIV prevention between males and females up to the age of 14. But after 14, the rates jump considerably in young women, suggesting a huge uptick in behavioral transmission. And this is further supported by UNAIDS in terms of some of their more recent data, who note that HIV infection rates for young women ages 15 to 24 are twice as high as those for young men. Last week at the International AIDS Society Conference in Australia, some of our colleagues from UNICEF presented some of the UNAIDS 2012 data that showed while deaths for non-adolescents have decreased considerably, deaths for adolescents have increased by 50%. And I think that that's really important for us to be thinking about and have in the back of our heads today. Over and above this, adolescent boys were 75% more likely than girls to die of HIV and AIDS. We can speculate that the male mortality rates may be higher because more of these young men are vertically infected or perinatally infected, since males that are behaviorally infected are many times not infected until they're in their 20s and 30s. Additionally, we can speculate that adolescent girls have increased access to life-saving services and reproductive health, as well as antenatal care. Regardless of the reasoning, it's important to think about and figure out how we can better prioritize adolescent care and treatment, including adolescent boys, to ensure that successful transition into adulthood. The second point on this slide is regarding adolescent adherence, which is such a huge concern. In one study, Dr. Nchega and colleagues noted a significant drop-off in adherence rates for adolescents over a 2-year period in comparison with adults. And so I'd like to ask you all just to think about for a moment adolescence and why this dropout may occur. And I think that many of you may come up with some of the same thoughts that came to me, and that is there's a lot going on in life as an adolescent and as an adolescent living with HIV. There's a lot going on. Some may be getting their first job. Some may have their first boyfriend or girlfriend, and really, who wants to take drugs when you're having that much fun? You may want to fit in, and so why would you stop to take your drugs? Why would you want to call that additional attention to yourself? Some may be tired, and some have just transitioned from pediatric care into adult care, and that's a rough transition. And lastly, like all adolescents living with HIV have a period of experimentation and high-risk behaviors. And that's why I've included the how to dodge a train icon or image up there. Many adolescents living with HIV, like other adolescents, are starting to think about love and sex and starting to think about families. According to one study from Uganda by Harriet Barungi, the desire to have children among all children, regardless of status, is strong, and a romantic relationship is often not regarded as legitimate unless it produces a baby. There are limited numbers of people that adolescents living with HIV can talk to about sex. Yet, realistically, their awareness of and knowledge of reproductive health and family planning and on HIV transmission also is really quite poor. There are limited conversations about sex with parents, and even with providers, it can take on a parental kind of relationship where the providers or counselors are talking about the ills of sex rather than being really willing and open to having a conversation. overall, there's a huge information gap that needs to be addressed. One study, again by Harriet Burungi in Uganda, studied 732 perinatally infected AL-HIV, and it confirmed the need to have such discussions around love and sex and romance. This study gives us pause regarding this specific group of adolescents and their awareness around the use of condoms, the limited use of condoms by sexually active adolescents, pregnancy amongst sexually active adolescents living with HIV in this study, and also the intentions of adolescents living with HIV, and specifically the young women, to have children in the future. Overall, I'd say that this study reminds us that adolescents living with HIV are teenagers, and they are thinking about love and romance, and they are thinking about sex. Okay, so moving on to where these worlds collide. In order to better understand how marriage increases the risk of HIV for young women, as has been stated by a number of different studies, we need to be thinking more about the variations in regions and whether sexual activity takes place in a relationship, in marriage, or outside of marriage. In Latin America and the Caribbean and some parts of sub-Saharan Africa, for instance, many girls and young women may actually initiate sex outside of marriage. In these cases, marriage may and may not be seen as a risk factor. In other cases, however, where marriage may be the first time that a young woman does have sex, we need to be thinking of this risk for these populations and for these groups. In the case of these marriages, these married young women engage in frequent unprotected sex. Additionally, women who marry young tend to have much older husbands, and many times they may be involved in polygamous relationships where the young women are the junior wives. Both of these factors may increase the probability that the husbands are infected and that the age and status of the young woman may weaken her bargaining power within the relationship. Additionally, married adolescents may have less information regarding, or less education and information regarding HIV. And lastly, the most common AIDS prevention strategies, such as abstinence and condom use, may just not be realistic for those married adolescents. While the needs of male AL-HIV are discussed very, very little, I would say that the needs of married male adolescents living with HIV are even less. And I keep coming back to that point because I don't want us to lose it. Lastly, we need to be thinking about the different age cohorts, and specifically the need to provide appropriate programming to meet the appropriate developmental stage of the adolescent. While a 14-year-old married adolescent girl may have some of the same treatment needs as a 19-year-old, realistically, they're at different places in their lives, and we need to think about that and consider. Additionally, at the end of the day, we need to remember that each young person is unique and has his or her own unique needs. We need to be thinking and talking about the future regarding adolescents, and specifically married adolescents and other adolescents that are involved in significant relationships. We need to be thinking of improved access to medical care and how we can provide non-judgmental access to appropriate method mix for family planning, and then other pregnancy prevention options that may be out there and appropriate. Additionally, we know that many women, regardless of age, find out that they're living with HIV only because of antenatal care. We need to work to identify pregnant adolescents living with HIV early and ensure that they have a full range of options for prevention of mother-to-child transmission interventions. And we also need to make sure that they have other access to other antenatal services. We need to be working with communities and facilities to talk about the benefits of couples counseling, to bring men into the fold, of testing and also overall family health. In terms of the access to medical care, it's not a world unto itself, and I do realize that. I mean, that would be putting it very simply. I realize that there are various and very important sociocultural considerations and challenges that we need to be talking about. We need to be talking about religion and tradition and culture, which often condone early marriage. We also need to be talking more about gender constraints that come into play and the power dynamics of sex. There are also additional cultural complexity, including who owns a woman that has been sold in through or has been provided a dowry or a lobola. And additionally, we need to be talking about who owns the children that a woman has had. Recognizing that adolescents living with HIV are here, and we need to better provide for all of them. We need to do a better job reaching out and also identifying the young men. And there are a variety of ways to do that, including family testing, couples testing, voluntary medical male circumcision, through the testing of orphans and vulnerable children, and the testing of young men who have sex with men. And then also thinking back to the pediatric days and testing pediatric inpatients, kids with tuberculosis, and kids with malnutrition. Additionally, we need to be working with married adolescents around beneficial disclosure and reducing feelings of stigma. There remains a need for targeted programming and support outreach for married adolescents living with HIV to ensure developmentally appropriate and relevant youth-friendly services. This takes place both through the clinical provision as well as through community provision, including peer support groups. Some of these services may include support groups that talk about care and treatment as well as adherence. And then we also need to be talking more about HIV prevention opportunities while working with spouses and for children and babies. And we need to be talking about sex and family planning needs. The support groups may or may not involve other adolescents living with HIV. They may include adult HIV support groups as well, but we need to be cognizant that the needs of married adolescents living with HIV are unique and that there are some additional considerations that we need to be thinking about and reaching out and providing attention to. We also need to be thinking more about the legal rights of married adolescents, both in terms of their right to consent to HIV testing, which is an unclear area in many countries, as well as their legal rights in terms of abandonment and the children that they have. Additionally, while young women remain a key focus of our HIV prevention care and treatment activities, we need to keep young men on our radar as well as they transition and marry. Lastly, I want to leave us with thinking about the importance of adherence support, as adherence support remains critical and just hugely important in all of our work with adolescents living with HIV. These two groups will likely have some similar and some different barriers to overcome. In terms of adolescents living with HIV that are married and those that are unmarried. But both require the support of both clinics and communities alike. Overall, we need to do whatever it takes to adapt our programs to meet the needs of adolescents living with HIV, both those that are married and those that are unmarried. Thank you.
Thank you. I know with our remaining panelists, we'll hear a little bit more about, since they'll be talking about programming on the ground, we'll hear a little bit more about efforts to work with those in plural marriages, different age cohorts, leaders, mother-in-laws, as well as young men and boys. But there were a few things that you pointed out which certainly caused me to pause in terms of considerations we must make for youth living with HIV/AIDS, and I think particularly thinking about pregnancy prevention versus safer pregnancy options for those when we think through reproductive health needs, especially in the context of sometimes needing to prove fertility early on in marriage. And I also think the difference between those that were perinatally infected and those that were behaviorally infected is certainly something that we could delve further into and perhaps maybe into our discussions a bit. Before I introduce our next speaker, I guess everybody now has a seat, but there's one more in the front if anybody can't see. But we're now going to hear from Suzanne Petroni, who is the Senior Director of Gender, Population, and Development for the International Center for Research on Women, who actually was a big advocate of us putting together this panel. So you can thank her for that, too.
Thank you, Sandeep, for pulling the panel together. It's fantastic that the Wilson Center is focusing on this issue, and it's also great that USAID kicked us off. I think USAID, as you all may know, has a wonderful vision for action to end child marriage and meet the needs of married adolescents. And I think, as Elizabeth noted, there's a little bit of work yet to do in terms of having the agency really focus on that. And so we're looking forward to commitments of new resources and new attention to both of those aims. So I'm going to talk today about a study that ICRW, the International Center for Research on Women, conducted last fall and through the winter with the support of the World Bank, where we looked at adolescent sexual and reproductive health in the slums of Dhaka, Bangladesh, focusing particularly on married adolescent girls. And with 70 million adolescent girls married right now around the world, 5 million of whom are in Bangladesh, this is an important population to focus on. So just very quickly, some background on Bangladesh. It's a very youthful country. About a third of its population is under the age of 15, and it's facing very rapid urbanization. So a lot of young people are coming from the countryside into the city in search of jobs and a better life, and the slums are expanding as they have been for years. Bangladesh has one of the highest prevalence rates of child marriage in the world. It's 66%, and also one of the highest rates of adolescent pregnancy in the world. Adolescent fertility comprises about a quarter of total fertility in the country, and as in many places we see around the world, death, maternal mortality, is the leading cause of death for adolescent girls here. And partly this is because there's very low use of sexual and reproductive health services, including maternal health. So we undertook a mixed method study, did a literature review, talked to about 10 donors about their focus and the gaps, and then did qualitative and quantitative research, and specifically, just very quickly go through these methods. A household survey where we interviewed 320 girls, 80 each from 4 very diverse slums in the city. All of the respondents were married adolescent girls between the ages of 15 and 19. And I show the age breakdown here because there was a heavier number or percentage of girls reporting to be 18 or 19. And I say reporting to be because there was a very high level of awareness in the slums that the legal age of marriage in Bangladesh is 18. So we believe there was an upward trend in the reporting, and because birth registration in Bangladesh is so weak, we really couldn't verify the age with birth certificates. So just keep that in mind. The qualitative research consisted of in-depth interviews, focus group discussions with married and unmarried girls, as well as young women and young men, and key informant interviews, mainly with people who work at health clinics or traditional healers. So let me turn to the findings. What we found was that roughly a quarter of the girls living in these slums between the ages of 15 and 17 years old were already married. Of the 320 girls, married girls in our study, the vast majority were married between the ages of 12 and 17, but we had one girl reporting she was married at the age of 9, and the average age of marriage was 15.2. More than half of these girls were married before they turned 15 years old. As we've seen around the world, there was a relationship between age of marriage and education, both the education of the girl and her mother. So girls who had completed primary education were significantly less likely to have married before the age of 13 than girls who didn't have any education. And similarly with their mothers, girls whose mothers had completed primary education were much less likely to have married early than those who had no education. Many of the girls reported having met their husbands while walking or transferring from the slum to work, and about half of them said that the marriages were arranged for them by family members, siblings, or parents. Most of the girls that we spoke with were unhappy in their marriages. They noted that their husbands didn't take care of them financially. They were often out gambling or drinking or with other women, and they just reported not being happy. And I've got a couple of quotes for you. One married girl said, "What are the good sides? I was fated for suffering. I don't see any positives in my fate." Girls said that they didn't want to be forced into marriage before they were ready, and readiness for them also included being able to have their own finances. So one of the girls said, "My sisters gave me into marriage when I didn't have the slightest clue what marriage was. I said, I don't want to get married now. I'm working in the garment factory. I want to do my job. Why are you forcing me to get married?" Coming back to education, a fifth of the girls surveyed had received no education at all, and just over half of them had completed 7th grade. And when we talked with the girls, they said that the need to bring in money, either for themselves or for their families, and in some cases, their families' demands were what forced them to leave school. Now, most of the girls expressed regret at having to leave school early, but some of them actually preferred to work because they could earn an income which gave them a sense of value, either for themselves, or they brought money in for the family, which made them more valuable, or they were holding on to money so that they could get a better husband when they were ready. In terms of work, just under a third of the girls that we surveyed worked in the garment industry, but slightly more than that had not worked at all in the past year. And there was a trend that we saw coming through the study where girls tended to come to the slums from the countryside in search of a job. They worked in domestic work for a few years until they were old enough to be hired by the garment industry, which was their ideal job. And I'll note that the 2011 DHS reported that at a national level, 8% of 15 to 19-year-olds in the country were working. So the numbers here, 30% and higher, are definitely quite a bit higher than the national average for this age group. So turning to sexual and reproductive health, more than half the girls, 52% in this study, the 15 to 19-year-old married girls, had at least one child. A third of them had never been pregnant, and 10% of them were currently pregnant when we did this study. The most recent DHS reports indicate that in Dhaka, about 29% of girls 15 to 19-year-olds in the country have already begun childbearing. And the vast majority of these, of course, are taking place within marriage. Our study indicates that the rates are significantly higher in the slums at 52%. So there is quite a difference here in regard to this population. And what this chart shows is that the girls, this is breaking down the girls in our study by how old they were when we interviewed them. And what it shows is that 35% of the 15-year-old girls in our study had already been pregnant at least once. 35% of 15-year-olds had already been pregnant once, and 84% of the 19-year-olds had already been pregnant once. The vast majority of girls who had no children said that they wanted two, and they felt that more than half of them felt that the children should be spaced 5 years apart. That was their ideal. And this was interesting. Even though more than half of the girls in our study already had children by the age of 19, nearly all of them thought that the ideal age at which to have children was at least 20 years old. No one said that the ideal age of pregnancy is under 18, and only 11% of them said the ideal age was 18 or 19. This chart's a little busy. I just want to point out here that married adolescent girls in the slums seem to have extremely high knowledge of contraception in general, and particularly of the pill, injectables, and condoms. And the specific methods that they knew about generally coincided with what contraceptives they were actually using. So pills and injectables first and second in that order. And indeed, modern contraceptive use among this population is actually fairly high among these married girls, 61%. And these rates, this is actually about 20 percentage points higher than the national average for 15 to 19-year-olds in Union. What we found was that age and wealth did not necessarily have an impact on contraceptive use, but parity does. So specifically, girls who had one child were 7 times more likely to be using a modern method of contraception than girls with no children. Girls with 2 or more children were 20 times more likely to be using a modern method. For those girls who weren't using contraception, the main reason that they gave was a desire to get pregnant or that they're already pregnant. About 16% said that they didn't believe they were at risk of becoming pregnant, and only a small handful said their husband prohibited it or cultural reasons. So the bottom line is that contraception for married adolescents, particularly for those children or those with children already, does not appear to be a major challenge in the Dhaka slums. What is a challenge is a belief or a social norm that becoming a wife and becoming a mother is the ideal, right? So this is what will need to change if we want to address adolescent pregnancy and we want to reduce the high maternal mortality among adolescents. I also want to note that we're not talking about unmarried adolescents here, but I do want to point out that when we had focus groups and interviews with unmarried adolescents, there was a very different level of knowledge, awareness, and certainly use of contraception. These girls, unmarried girls, reported extremely low levels of knowledge and awareness about any methods of contraception, and none of them reported using contraception. Part of this is likely because premarital sex is so highly stigmatized in Bangladesh that nobody talks about it, but it's also potentially due to the extremely limited access to contraception for unmarried adolescents, and this is either due to organizational policies or perceptions of policies, but it's a significant impediment to their ability to access services. Menstrual regulation is permitted in Bangladesh for up to 10 weeks pregnancy, and abortion is not permitted after that time. And what we found from the survey is that there was very low reporting of both menstrual regulation and abortion. But the findings are relatively uncertain because in the qualitative interviews we did, there was much more discussion about a higher frequency of abortion and menstrual regulation. The low reporting is likely due to stigma around abortion. And I'll just read this quote that shows that dirty people go to have an abortion, right? There was this very clear distinction between clean and dirty, good and bad around a number of behaviors, including abortion. There were no reports of HIV infection by the girls, but many of them had reported having a sexually transmitted infection or reproductive tract infection. And when we dug further into this in the interviews, we found that the girls, the young women, and the young men, they demonstrated very low awareness of symptoms that are commonly associated with the regular fertility cycle and the menstrual cycle. And they often attributed symptoms of regular maturation, puberty, the fertility cycle to a disease or an infection. So, for example, the main sexual and reproductive health concern that was cited by the girls were those associated with white discharge or with abdominal pain or excessive or insufficient bleeding. These are all typically normal manifestations of the fertility cycle and the menstrual cycle. But they were seen as these girls as an infection, and in some cases even being infected by the evil eye. They were cursed, and many of the traditional healers in the communities perpetuated these myths and misperceptions. So that's definitely something to address. Young women in Bangladesh tend to access health services, including antenatal care, at very low rates. Recent data indicate that even in urban areas, only about 45% of pregnant women had attended the WHO recommended number of 4 antenatal visits. Our study finds even lower rates in the slums. While 3/4 of girls had received at least 1 antenatal visit, only 1/4 of them had the recommended number of visits. 70% of the girls who had delivered did so at home. And these are similar findings to national levels. And the reasons that they gave for not delivering in a health facility were it wasn't customary, it cost too much, and in some cases they said they didn't have time to get to a health facility. Also, 5% of the girls who delivered at home did so because their husbands or in-laws wouldn't let them out of the house. Concerns about using sexual and reproductive health care, including maternal health care, included embarrassment about talking about sex or about pregnancy, concern that others in the community might note their business, and bottom line, that it just was not seen as appropriate for adolescent girls, married or not, to be talking about sex and sexuality. Lastly, this study, and particularly the research that we did with young men, demonstrated that gender-based violence is quite common in these communities. Many respondents in the survey, again, married girls, expressed disapproval of such violence, but a high percentage of them believe that spousal abuse was acceptable in a number of circumstances. And you may not be able to see this clearly here, but this shows the percentage of girls who say it's okay for a husband to beat the wife if, for example, 13% of these girls believe a husband is justified in beating his wife if she refuses to have sex with him. Nearly 29% believe it's acceptable for the husband to beat her if she goes out without telling the husband. 35% believe it's acceptable for the husband to beat her if she doesn't take care of the house or the children. And 55% say it's okay for him to beat me if I show disrespect to my in-laws. Girls were more hesitant than boys to discuss gender-based violence and harassment openly, but when they did, it was very clear that this is a daily occurrence. Rape, both inside and outside of marriage, is a daily occurrence for these girls. I want to close with some recommendations that stemmed from our research. I focused today mainly on the findings regarding married girls, but the recommendations that we have, and there are many more of these that we provided to our donor, the World Bank, address the needs of unmarried and married adolescent girls and boys. Basic fertility awareness education for girls and boys well before they're married can help with their basic awareness of their own bodies, their fertility, and their mental health. These girls were distraught that they had what they thought were infections when in reality they were just having a normal symptom of puberty. There needs to be clarification of whether service providers can provide sexual and reproductive health services to unmarried adolescents. There is nothing in the laws and policies of the country that prohibits it, yet there is widespread belief that there is a prohibition on such care. The legal age of marriage for girls is 18, for boys is 21. Clearly, this is not being enforced. It absolutely must be. And part of getting there is to enhance the birth registration and civil registration of the country. But there's much more that needs to happen there, obviously. Obviously, education for girls, I think we all know the many benefits that provides. Changing gender norms, changing this perception that girls are wives and mothers first and foremost, can go a long way toward improving their own well-being and certainly age of marriage and age of pregnancy. The gender-based violence, the stories that we heard were horrific, and GBV is just so normalized in these communities, and it really stems from this perception that girls are less than boys, women are less than men, and we really need to change that. And then finally here, I have a point about working with the garment industry. Because so many of these girls do work in the garment industry, it provides a tremendous opportunity to provide them with information about their sexual and reproductive health and their rights. And then lastly, a point that's not on here is the need to normalize sex and sexuality. Just as Elizabeth said, adolescents are having sex, they're curious about sex, they need information, and to continue to stigmatize it is damaging to their health. Finally, it's important for those of us who work on family planning to understand what is driving early pregnancy and desired pregnancy. Again, tackling gender norms that are driving these girls to want to be a mother, that's the ideal. Helping adolescents to understand their reproductive desires and then to act on those reproductive desires has to be a part of a comprehensive package to provide adolescents with family planning and reproductive health. And this picture here is of a new study, a report that ICRW just put out on this very topic, adolescence and family planning. We have some copies of it outside, and you can also find it on our website. So I want to thank again the Wilson Center, also acknowledge the BRAC Development Institute in Bangladesh, which was our research partner, David Snyder, wonderful photographer, and the World Bank for funding this study.
Thank you, Suzanne. I think you really spoke to the need for youth-friendly services, and I think your comments in particular about reaching young women in the workplace could be a very, very effective strategy, and I know we're going to hear about some more effective strategies in a few minutes from some of the programs that Pathfinder and CARE are involved with. I do think that you said something that really resonated with something that Elizabeth said too when you talked about the women or the girls saying that they were 18 and 19 when they just weren't. And I think going back to the point, Elizabeth, that you made about needing to have a better understanding in many countries of the legal rights of married women under the age of consent or married girls under the age of consent is something that we certainly worldwide need to explore a little further. So why don't we move on and hear a bit from Doris Bartel, who's the Senior Director of Gender and Empowerment for CARE. And for those of you who may recall, we heard a little bit about CARE's work with the Tesa project in, I think it was June of 2013, so we're going to have a little bit more of an update. But I do want to point out, if you are interested in hearing more or learning more about what that event was, we have our event summary out front at the desk, and it also will give you a link to the archive video of that event. So every time we do an event, it's either live webcasted or archived, and then we do an event summary that teases out some of what the discussion was. So thank you, Doris.
Thanks, Sandeep, and thank you for inviting me, and thanks for the Woodrow Wilson for organizing this event. I'm here to share a little bit of the lessons and the results of working with married adolescents in a project called Towards Improved Economic and Sexual Reproductive Health Outcomes for Adolescent Girls. It's a long title, so we usually shorten it and call it TESFA. And in this particular presentation, I'll be sharing some of the end-line evaluation results, particularly focusing on sexual and reproductive health. This project was funded by the Nike Foundation and is a joint collaboration between CARE, and which designed and implemented the project, and International Center for Research on Women, which led on the monitoring and evaluation. This project was implemented for 3 years, and it just ended last year in the Amhara region in Ethiopia. The intervention targeted 5,000 ever-married girls aged 14 to 19. It was a quasi-experimental research evaluation with 3 intervention arms. One of the arms, the girls were involved in economic empowerment, building basic financial skills and experience. In the second arm, focusing on sexual and reproductive health. That's education, anatomy, puberty, as Suzanne mentioned, reproductive health information, as well as links to the clinics offering both HIV and reproductive health services. The third arm combined both of these elements in a customized package, and the last group was a control group where we could use for comparison purposes. And all arms included a component of community support and social norms change. This slide shows some of the baseline data from the cohort of girls that we worked with. So these statistics represent that particular part of the Amhara region. And I won't read the statistics to you, but you'll get a sense of the overall picture from some of these data. There's very high rates of child marriage in the Amhara region in Ethiopia, most around half by the age of 15 and most by the age of 18. These marriages are frequently arranged by family members, and as Suzanne and others have mentioned, high rates of divorce and partner violence and very low use of reproductive health services. Most have not completed elementary school, and a third have never been to school at all. And most say they have very little say in their own lives or even control over their own bodies. A third say someone else makes their contraceptive choices for them. The girls are extremely vulnerable, partly because of social isolation, and so they often fall through the cracks. And there's very few government or other programming designed specifically for married adolescent girls. So I won't go into too much detail on this slide. This describes the interventions, which I've already mentioned, but each girl got life skills training and also either reproductive health, peer education and support, or economic empowerment, peer education and support, or both. Each of the peer education arms also received a systematic community support that focused on stakeholders, so the other members of the community, either religious leaders or other parents or other adults, their husbands, so that those girls' empowerment was supported by others in the community. So the results I'm going to share with you today are specifically from the sexual and reproductive health arm of the program. So now moving into results. I would like at this point to just point out the picture, the photo in this slide. Part of the evaluation of this study was done through a participatory narrative approach called Photo Voice, which gave girls cameras and training and support for taking their own photos to tell their own story about what happened in the last 3 years of their lives and what results they'd like to share with others about that change. So this is a photo that was taken by one of the girls, and she shares with this photo the quote that she'd like you to take away from it, which is, "This is me taking injection contraceptive. This is after the Tesa project. I have one child and I want to wait until my child becomes strong." It's an incredibly powerful narrative, given the lack of family, community, and clinic support for girls to use contraceptives, even for child spacing prior to the start of the project. I think this represents the normality of the pressure from families and communities to start childbearing early for that age group. One of the main barriers for the married girls in choosing contraception was their lack of knowledge about it and also that intense pressure. The statistics on the right of the slide show the percentage point improvements in some of the outcomes that we were hoping to see. So you'll see, for example, 29% increase in the use of health services. That was specifically utilization of the clinic services for contraception in the last 6 months. And this represents increase from baseline to end line, so that's a 30% improvement. You'll also see almost 30% improvement in contraception use and almost a 20% increase in HIV testing. There are additionally improvements in communication with partner, in decision making, and in violence, but I'll share a little bit more about that in a bit. So just to give you another sense of the data from just a different slide, a different way of looking at it is in the bar graphs, which I'm showing here. And this shows the changes from baseline to end line and some of those key data points for the girls. Increases in confidence in using condoms, in using modern contraception, in going to a clinic for contraception in the last 6 months, and going for HIV testing. So this shows the improvements from baseline to end line. So these increases were much larger than that seen in the control group that I mentioned earlier, and these changes are all statistically significant. So just to look again at the data in another way, to compare the 4 arms, looking at some of the outcomes, one particular outcome, which is visiting the clinic to obtain contraception, you'll see that the increase from baseline to end line that I just showed you in the last slide in the bar graphs, in blue, the blue bar going up shows an improvement between 52% to 81% from baseline to end line, and you'll see that it's greater in the group that got the reproductive health interventions only, more so than the other groups, although all of them went up. And that the difference between this and the control group were all statistically significant. I also wanted to include some slides on the gender dynamics and the relationships between the girls and their families, and in particular with their husbands. So I'm sharing here this slide, which is again a photo voice photo taken by one of the girls that represents the changes that she saw in the relationship with her husband between the baseline and the end line, the duration of the project. In this one she says, "This is my husband washing his feet. This used to be my duty, but now he's doing it by himself." Both partners in this relationship are going out into the fields and working in muddy fields all day, and they both come home with muddy feet. So the change in dynamics where they're both washing their own feet, I think is significant for her. It's not something that we would think to ask about, but something that she chose to remark on as a significant change in the dynamic of their relationship, which I think is interesting. We also did qualitative interviews, and which showed increased couple communication, particularly in marital relationships, but also significant reductions in gender-based violence, and in particular sexual violence or forced sex in marriage. So the last slides, again, just to share with you some of the voices and the remarks made by the girls themselves in this project through the Photo Voice project. The rest of the slides here are from that project. In this slide, you'll see a man pouring some batter onto a griddle on a fire. He's making the kind of pancake or bread that they use in Ethiopia. It's called injera. And her remark here, the participant wrote, "This is my husband helping me make injera. Every week when I make injera, he would bake one to learn how to do it, and he's proud of doing it." In this photo, the participant writes, "My husband can now feed my baby daughter if I'm not around." You'll see workload comes up as a theme in the photos and in the remarks by the married girls. And I think that part of the reality of the lives of married girls is that, their lives are very, very busy. Their workload is incredibly heavy, and so it represents a big part of their world. And to see changes where people are helping them with it and it's seen as more equitably shared, I think is significant. So this one, the caption is, "This is my husband helping me fetch water." In this photo, she writes, "I'm able to travel to market, loading grains on animal pack." I think we do need to think about mobility as an issue for adolescent girls. In this particular study, one of the main findings was the social isolation of married girls, particularly in rural areas. Once they leave their natal home and go to their marital home, they're really isolated from peers, from other family members. And the fact of providing opportunities for peer support and for going outside of their home, and the mobility factor that improved, I think, was one of the significant findings, I think, from their perspective. It's one they talked about quite a bit. So I'll leave you there, but I will say thank you very much. This is a project that was, as I said, a joint collaboration between CARE and ICRW, so I'd really like to thank especially Fevan Tesa, who led the program implementation and design from CARE Ethiopia, Jeffrey Edmedes from ICRW for leading on the research and evaluation, Robin Hayes, who really led the photo voice and the qualitative work, and of course the adolescent girls in this project. Thank you.
That photo voice project is really particularly interesting. I know I was flipping through your slides before as I was prepping for the meeting, and to really hear more about the quotes and what's behind the quotes is particularly interesting. I know that here at the center too, we're trying to take a closer look at storytelling when we talk at these issues and about these issues, and we've done a series of films, but the photo voice in particular is really interesting. You talked about the different arms, and I'm going to take a little moderator liberty and ask you one question in between the presentation. You did say that that the folks the girls that had the arm that was focused on the sexual and reproductive health education had significantly increased results and outcomes around that. Do you have particular thoughts on why that is? Why that particular intervention was the one where you saw the most increases when it comes to?
Yeah, I mean, in this slide set, we really focused on the data, the reproductive health outcomes and behaviors in the data set. There are many other points, regarding decision making, communication, relationships, economic empowerment outcomes, savings. So just to look, to hone in on the reproductive health outcomes was the focus of this slide set. It's true that of the reproductive health outcomes, they showed up strongest in the arm that was focusing on the reproductive health interventions. So surprise, it works. And in many, it could be some kind of dose response, even, if you're comparing the kind of reproductive health outcomes in the one with the combined intervention versus the one in just the reproductive health only. So we can talk about that more in the discussion, but
Right.
Some interesting nuances there, looking at interventions that focus specifically on particular issues versus one that's more holistic or combined with others.
I just wanted to hear you say it works. Although I think some of us knew that already. So why don't we turn our attention now to Callie Simon, who's the technical advisor for adolescent sexual and reproductive health for Pathfinder. And Callie's actually going to expand a bit on the description of Pathfinder's work that we heard about in September with married adolescents. So again, if you're interested in that particular session, I know they had some of the staff members they have based in West Africa, as well as, was it Ethiopia?
Mm-hmm.
Yeah, that's what I thought. Come to that event. So if you want more information about that, the event summary is outside.
Great. Wonderful. Thank you so much for having me here. It's such an honor to present here at the Wilson Center and with all of my fellow panelists. And I think this is it's nice that I get to go last in some ways, because first I'm presenting an ongoing program, so it sort of seems appropriate for the last presenter. It also, I think, will illuminate some of the key themes that we've heard from some of the other presenters around the needs of young married women. And today I'm going to tell you a bit of a story. Sort of a design story. How did we think about a program? How did we learn from other programs? How did we adapt that program model? How have we started to implement, and what are some of the emerging challenges and lessons and questions that we have around that program focused on young married women, ages 10 to 24, particularly young married adolescents 15 to 19, in Guinea, Burkina Faso, and Niger. So our story begins with kind of an amazing opportunity that Pathfinder had to design a program, and the only real instruction we had is that it needed to focus on adolescents and youth, which is pretty much my dream moment. And so we were able to think about things and to look at some of the data in the West Africa region and really think about what would be appropriate as a target population, as a population with whom we wanted to work. And this is where we landed on young married women, and I think some of the reasons for that are articulated here on the slide, and that the region, most of us know, has incredibly high rates of child marriage, and we know that nearly all of the childbearing in the region happens within the context of marriage. And when you look at married adolescents, the use of modern contraceptives is incredibly low. You can see on the slide, and it's lower than compared to older women and all women. We also looked at adolescents and youth in the region and read quite a bit of research and emerging evidence coming from some of the work that those of you in the room are doing and other places, and saw that married young women, married adolescent girls, are particularly socially isolated, which I think is a theme that Doris brought up, that they have been pulled from their home when they got married. They have been forced to drop out of school. They have been moved to live in their husband's family, often as the junior wife with many co-wives, and often to a much older man. They are rendered virtually powerless vis-a-vis their male partner, other co-wives, and they have been sort of ripped from their existing social network, or what they used to have as a social network. We also did a kind of a landscape analysis and found that there are very few programs really focusing on this population, especially in West Africa, but really globally. It's a huge population with huge needs and unique needs, and very few programs. We found one by Pop Council in Burkina Faso, and maybe there's more now, but that was it at the time, focused on married adolescent girls in a region with such high rates of child marriage. And so we decided to design a program, and we were able to look at 2 ongoing programs that Pathfinder was working on that was focusing or had specific strategies for this population of married adolescent girls and young women. And we were able to tease out what some of the key program features are or were of those programs, and how we might think about adapting them or using them in the West Africa context. So the first project that we looked at was the Prachar project in Bihar, India, implemented for 10 years and showed significant impact on the use of contraception among young married women. And the Gender Roles, Equality, and Transformations project, which is led by the Institute of Reproductive Health at Georgetown, implemented by Pathfinder and Save the Children, funded by USAID, and has some clear strategies that are geared towards very young adolescents, older unmarried adolescents, and then married adolescents. And so we were able to look at these programs and really think about how we could use the lessons that were learned in those programs and apply them to a new context. So here are some of the things that emerged as key program features, or some of the elements of those existing programs that we thought were, or had been shown to be effective through evaluation, that we thought would be useful in designing a program in West Africa reaching this population of young married women. And the first one is to address the sort of structural, social, and individual factors. So it's an ecological model, and the idea is that young married women, married adolescent girls, have so little power and decision-making over their bodies, over their choices, over their lives, for all of the reasons that my fellow panelists have already mentioned. Gender norms, cultural norms around fertility, lack of education, lack of access to services, and we have to look at all of those competing and driving factors and think about how to address them in a program. We also saw in some of the existing programs the use of the healthy timing and spacing of pregnancy lens, which is basically this idea that we can talk about family planning and choices around contraception through the lens of a healthy mother and a healthy baby. We also found the importance of engaging not only the young women, but their male partners and other men, recognizing and addressing social isolation, engaging key gatekeepers, mothers-in-laws, and others, and some of the key program strategies that had been used, like home visits to young married women, recognizing their extremely limited mobility, that often these women are either unable to leave the house unaccompanied, or the incredible burden of chores and childcare that they are sort of saddled with as the youngest member of the household, or a co-wife or a junior co-wife, renders them unable to go out and seek services actively. And finally, we found that both of the programs we were looking at had tried to increase access to respectful SRH services, but I'll touch on this a little bit, and I think we identified this was an element that could have been improved in future programming. So we had these sort of key program elements, and we thought, now how do we adapt them and apply them? And so we looked at our ongoing programs in the region, DHS data, emerging evidence from some of you in the room as researchers, talking with our local partners, with program staff, and identified some key contextual factors that are unique to or important to Burkina Faso, Guinea, Niger, and tried to think about how we could incorporate those into the adaptation of the program. So young married women are married very, very young in West Africa, often to much older men. They often have co-wives. There are very limited family planning, reproductive health service delivery infrastructure in general. That's one of the reasons for all of the ongoing work in the region now around the Ouagadougou partnerships and everything. There are some specific key influencers, mother-in-laws, which we also see in other parts of the world, of course. Young married women mentioned to our partners during some formative research that they were looking at, that they also talked about aunts and uncles, father-in-laws, co-wives, religious leaders. as has been articulated already today, young married women felt culturally extreme pressure to prove their fertility upon entering marriage. A woman who had not gotten pregnant within a year of marriage was eligible or was considered, it was considered appropriate for divorce at that point. We also heard that there was some pressure to closely space births, which you don't always hear. I mean, that's sort of an interesting finding that some of our local partners shared with us. They said that there's some sayings in Burkina Faso, for example, where a mother-in-law is often saying to a young woman, well, isn't that baby on your back getting heavy by now? Sort of implying that it's time to have a new baby, a new one to carry on your back. In talking with our local partners, we also identified some key entry points around discussing reproductive health and fertility in the context of healthy mothers and healthy children. So we took all of this into consideration in this sort of story of how we designed the program, and we landed on the structure, or on the program design that you can see on the screen here, and I've articulated it in that ecological model to show how we came up with interventions that would address the structural, social, and individual levels that sort of drive adolescent girls' lives or govern their lives in many ways. At the structural level, we felt like it was very important to engage with the national health system. This isn't always critical, but in our role, we felt like in Burkina Faso, Guinea, and Niger, the health system and the national government was really ignoring adolescents and youth more broadly. They were especially ignoring the unique needs of particular cohorts of adolescents and youth, like married adolescent girls. And the service delivery for adolescents and youth was weak at best. There's a huge reliance on the sort of outdated and not based on evidence youth center model, where you build a giant building and expect youth to come get services and young men or old men show up. Adolescent married girls certainly don't show up. There is less emphasis on service delivery for adolescents in general. So we felt like it was very important to have some advocacy strategies, to have some training, to have some really important interventions there. We also supported the development of small groups for young married women to reduce social isolation. The local partners initiated community dialogues with mothers-in-laws, husbands, trainings for religious leaders focused on the importance of healthy timing and spacing of pregnancies. And then community health workers were trained to conduct routine home visits with young married women to talk with both the young married woman, but they were also trained that when they encountered a co-wife or a mother-in-law or a husband, how to engage them in the dialogue. And we did a lot of practice and rehearsal with community health workers to sort of help navigate that really difficult dynamic when you arrive at a household. In the West Africa region right now, there's quite a push around community-based distribution of contraception, and we recognize that that's an important opportunity for women to receive contraceptive services, but often CBD agents are less likely to reach out to young married girls. They think they don't need contraception, that they should actually be proving their fertility, so why should I offer contraception? And so we worked with the existing CBD agents to try to help them reflect on some of those biases they have and help shift some of those biases so that they are able to offer the same level of quality services that they need to offer, that they offer to older women, or they should offer to older women. So the project was implemented, or has been implemented, in partnership, as I mentioned, with a few local organizations in each country. It's also been implemented in partnership with the public health system in each country. It's a fairly small project. Pathfinder typically implements projects at scale with adolescents and youth, and this one is more of a program that we're trying to implement in two areas in each country. So one rural and one peri-urban area in Burkina and Guinea, and two peri-urban areas outside of Niamey and Niger. It's just now starting in Niger. It's underway in Burkina, and it's been recently underway in Guinea, but has run into a lot of challenges with some of the challenges in Guinea, that strikes and Ebola outbreak and other major issues happening in the country. So that's been a bit of a rocky road. As I mentioned, it's a relatively small program because the idea here is to look at the feasibility of this particular model in this new context. And is it working? Do we have all the right pieces in place? Are we addressing sort of the right components? And so we've built in some learning processes there for us to learn from this, potentially adapt the model, and then scale it up eventually. So I've mentioned here some of the progress to date, and I think that there's a real dearth out there of materials for programming for adolescents, for married adolescent girls. In fact, some of the materials used in Tesa are some of the only ones I've seen. I'm sure there are a few others, but there's a real lack of training materials and tools and resources and content for this population. And so we adapted some existing tools and developed a supplemental training curriculum for healthcare providers. So it's supplemental to the government's youth-friendly service training. The youth-friendly service training covers a full range of sexual and reproductive health issues, and we developed a 1.5-day training that's supplemental to that really talks about the unique circumstances of married adolescent girls in the country, the unique pressures they may be facing, some of the gender dynamics, and healthy timing and spacing of pregnancy. Did the same thing for the training for community health workers, and we developed a training curriculum for small group facilitators who are also young married women. They're selected based on some level of literacy, willingness to be a small group facilitator, and they're trained to facilitate a group of their peers around things like life skills, puberty, healthy timing and spacing of pregnancy, gender dynamics, those sorts of things. So because the project is underway, I think one of the main contributions I can probably make to our discussion today are to raise some of the challenges that we're having and some of the considerations that we're grappling with for future and for further discussion. So the first one is that we are recognizing the need for a significant level of capacity building of local partners and government partners around programming for married adolescent girls. For a long time, those of us in the adolescent and youth field have been doing programs like peer education and youth-friendly services, and there's sort of this idea that this is how we do programming. And when we go into work with partners and we're talking about a unique subset of adolescents and youth with really different needs, there's a need to shift the mindset around what are the best strategies to reach that population. Peer education, it's often done with slightly older men reaching slightly older men or youth, like the 20 to 22-year-olds, not reaching the most vulnerable married adolescent girls. So how can we adapt those programs? And so we've been doing a significant amount of capacity building around that, and we've had to sort of revise our project expectations accordingly. Similarly, we've been working very closely with the ministries of health in the 3 countries to think a little bit differently about youth-friendly services. So youth-friendly services are critical services that are responsive to the needs and the rights of adolescents and youth, of all different kinds of adolescents and youth, are critical. But the way we implement them is it doesn't have to always be the same. It doesn't have to be a separate room in a facility where all the adolescents and youth go. We can think about making maternal health services youth-friendly. We can think about making child health services youth-friendly so that the women who bring in their children are counseled on sexual and reproductive health services. And so how can we think a little bit differently about youth-friendly services? And we're in ongoing dialogues with the ministries around that topic. We've had some challenges in monitoring the project because we're using public sector service delivery. HMIS is not always age disaggregated. It's rarely age disaggregated. So how do we know we're reaching adolescents 15 to 19? And we probably shouldn't ask marital status because that can discriminate against unmarried adolescents. But if we don't ask marital status, then how do we know if the married adolescent girls are seeking services? And so we're really grappling with some of these questions. And the idea of making sure we are able to collect data to know the program is working or to correct challenges while not creating a parallel system and not creating a system that would stigmatize any other populations. We also recognize that the influence of co-wives is an important one. We've had a lot of dialogue with partners and others working in the region about this, but we'll be honest to say that we're not quite sure yet what that relationship is between the most junior adolescent married girl wife and the older co-wives, and how do we design a program that appropriately addresses that relationship in relation to the ability of all women in the household to make decisions and govern the gender dynamics or navigate the gender dynamics that govern them. So we're still exploring that and thinking through that. And finally, I think my presentation highlights our process of thinking through a program, of adapting a program, of developing a program, of implementing a program. And one of the things that we've learned in this process is the real need for evaluations of programs like Tesa. So it's great to have those results, and other programs focus on this population so that we have a much stronger evidence base with which to know kind of what are those key interventions and how might they be adapted and how do they work in different contexts. We're documenting this project and trying to learn from it in partnership with our colleagues at the Evidence to Action Project. And so we're hoping that will shed some more light on this. But we look forward to continuing to learn with you and together. So thank you very much.
Thank you, Callie. I certainly think you took us a step further. I know we talked a little earlier about, young women who are married needing to prove fertility, but then also taking the discussion to the pressure to closely space children was something I think in particular was good to note. I also think your conversations about training for and curriculum for service providers, on capacity building, on youth-friendly services brings us full circle back to some of what we heard from Elizabeth earlier around stigma and perhaps needing to work with healthcare providers around that as well. And also your comments about isolation, I think, took us full circle, and then how you broke it down, the difference in feelings of isolation between those that were behaviorally infected and those that were perinatal infected. I think the order of this worked out well, I think, given that. I had nothing to do with that. So I do want to open this up for discussion now. I know that there a few of you might be at the edge of your seat because we heard some great presentations. So does anybody want to kick us off in particular? It looks like we have one on the side here.
Well, thank you. I'm Regina Benevides from the Evidence to Action Project. And first, I want to thank all of you for really, really good and very provocative presentations. But my question goes to Callie, and because during your presentation, you have mentioned about the need of shift the mindset about the approaches for young married women. And I know that this is part of our discussion, but I would like to listen to you a little more about that. Could you please evolve a little bit? Because we have been talking about these youth centers that are not really for all kinds of adolescents and that they don't respond to all their needs. We are talking about the needs of having specific approaches, but what else? What comes next? So I would like to hear you more. Thank you.
We can collect a few if there's another burning one, or we can start with that. Why don't we go ahead and start with that then?
Okay. It's kind of a tall, oh, I'm breaking my microphone. Sorry. Is that close enough? Because I was scared to touch it again.
Yeah, no, that's fine.
Yeah, thanks, Regina. I mean, that's an interesting sort of invitation to just expound on what I think is most interesting about this. But I mean, I think one of the things that all of the presenters have highlighted is that it is, we have long known that it's important to stop talking about adolescents and youth as if they're one homogenous group. They're all very, very different. Today we're focused on sort of married adolescents, and even within that, I was saying our project has sort of married young women, and we were trying to narrow our focus to 15 to 19, but we do have some that are slightly older with very different needs and mindsets, and some that are slightly younger with very different ones. And even within that, we have the sort of first-time parent population, which are often married, not always married, adolescents who have had a child. And I think that some of us, especially, I mean, I hear it from the organizations who are presenting today, have been thinking a long time on this and really evolving our thinking on this. But I'm finding more and more in my travels, and I don't know what you all think, I'd open it to you, that a lot of our thinking isn't reaching sort of the implementation level on that piece. We're still, programs are still being implemented on the ground as if it's adolescents and youth as a block, and our programs aren't being tailored appropriately, and to do so requires significant shifts in thinking all the way down to the lowest level of implementation. And I think we've been I don't know if surprise is the right word, but we've had to rethink a bit how our expectations in terms of timeline and level of effort for capacity building on our project to be able to move in that direction. And it's been a learning experience for all of us involved in that in the 3 countries. So I'll stop there, but I think that this is something that others could probably expound on as well. Thanks.
Does anybody want to add to that?
No, I mean, the one piece that I will add is just in regard to the diversity. I mean, what I found interesting in looking at so the HIV issue and then Bangladesh, East Africa, West Africa, just the diversity of talking about married adolescents within those contexts. So, you know, even if we're looking at 15 to 19-year-old married adolescent girls, they're hugely different contexts. So just, I don't think that's a point we can stress enough.
But I think to add to that, I think each of us comes to our programming and our planning with bias. And that came through in all of the presentations here too about clinical services and government services that are designed in a way that have this idea, maybe magical thinking about what the reality is out there without really designing it with the clientele really in mind. And so just the real importance of asking the question, what is the reality for you, and designing programs and interventions that are targeting that realities of their lives. Yeah.
You know, before I actually open it up for more audience questions, I do want to make sure that you all have a chance to ask each other questions too. If I think we fail to do that sometimes. So if anybody wants to ask another, feel free to chime in. Otherwise, we do have a question on the side. Otherwise.
Thank you. I'm Dave Rabinowitz, and I have a couple of questions. First, for Doris and Callie. There are a lot of organizations that are working on young women empowerment in the third world, and you are both doing programs with some sort of training aspect to them. I was wondering if your curriculum materials and such for life skills, economic, and SRH training are generally available to other organizations.
Yes.
I mean, is there a website where they can find, or do they have to contact you, or how does that happen?
Yes. In this particular case, for these particular ones, yes, you'd have to contact me. So please come talk to me afterwards. Yeah. But yes, they're definitely available generally.
Good.
Yeah, same answer. Contact me for these, but they're going to go on our website soon. Right now, they're in French and English. So
that's the beginning. Okay, my second question is probably going to be a little bit familiar to Sandeep, because I asked it earlier this week, in effect. But in recent years, I asked it differently. In recent years, there's been a substantial reduction in birth rate in certain South American countries. And some people were wondering why that was happening, and they did some research and discovered it was based on telenovelas, basically soap operas, where the key characters were well-off women who had small families, and they served as role models. And I was wondering if in any of your areas there are TV or radio soap operas or other fictional programs with characters that serve as good role models, perhaps with HIV, perhaps young married women, things like that.
I've already, you can.
Yeah, so in South Asia, the Population Foundation of India has launched a very popular nationally televised soap opera that is, it's television as well as radio programming and community discussions and call-in and so forth. I Woman Can Do Anything, I think is the name of it. You can see trailers on YouTube. It's fascinating, and they've tackled a wide range of issues related to child marriage, sex-selective abortion, gender-based violence, just you name it, and they are tackling it, and they've had some very powerful results. Poonam Mutreja, who's the head of Population Foundation of India, was actually telling me at the Girl Summit last week, we were watching a trailer. They had set up this call-in system for people to record messages and then request callback if they wanted more information. They expected maybe 1,000 calls after each of these shows. They've had 300,000 calls so far, and just amazing responses. And she gave me one example of a 12-year-old girl who called in and said, I am so happy that this show is on television. Because of watching this show, I know that I don't have to get married when I'm a kid. I know I don't have to give birth at 15 like my sister did. I'm going to be the next president of India. Cool.
Suzanne, how come you didn't say the name in Hindi?
You know what?
Yeah, I do. It's me, kuch bhi kar sakti hu. So the I woman is just, yeah, just like that. The I woman part is that it's in the verb tense that's female. But I do want to mention that that's actually the answer you got on Monday, too.
Yeah.
So this,
There are others. So Suga in that MTV Staying Alive Foundation has done in South Africa and Nigeria, Kenya. Yeah, a couple of, so that's really good. Puntos de Encuentro has done some in Central America that I think they've tried to replicate. Someone, I mentioned Gary Barker earlier, and the work that he's done at Promundo. They have video series that is cartoons with no language whatsoever, and so they can be used in any context. Tremendously powerful in terms of tackling gender norms and early pregnancy and early marriage and all of these issues. So,
well, I actually liked that you heard that answer. Somewhat of that answer today, too, because I do want to point out that the Wilson Center has had a strong partnership with the Population Foundation of India. We actually traveled there last April and co-hosted a full-day meeting with maternal health experts. The next day, the rollout of that meeting was then video conferenced into an audience here as well as at Harvard. So all that is available on our website. And then we had Poonam here, actually, I think it was September. September was a good month, where she talked a bit about that soap opera as well. So those are two places that you can learn more about that. I think we have a question here in the middle.
Thank you. My name is Michelle Farmer. I'm with Chipaigo. I want to thank all of you for your presentations. Very thoughtful. We've heard from other presenters, and maybe some of you also have been involved with some of the work involving health and adolescents and the positive impact on that. And I just wondered specifically where young married adolescents are concerned, what do you think the potential is for reaching that specific group of young women? Thank you so much.
And I'd actually like to just build on that question too. And if Elizabeth, you can talk to us a little bit about how health may have worked with adolescents that if you don't know in the married context, since we were talking about how there was not a lot of research around that, if you could speak about unmarried and how it might apply then, you think. So since I posed that to you, I don't know if you want to get us started.
Yep. Thank you. Thanks, Sandeep, and thanks, Michelle. I think that there are a lot of opportunities to bring in mHealth. I think we're continuing to explore these opportunities and specifically to evaluate what is, what's already out there and being done. And I think in terms of thinking of around HIV, I think there is a concern regarding confidentiality that has to be thought of and thought through very, significantly before things are rolled out. But I do know that in the context of HIV programming throughout sub-Saharan Africa, I know that there is some significant work that's starting to be done and that is, in process currently. But I would say more around text messaging. And then I think in terms of some of the work that Suzanne was talking about, in terms of telenovelas and different, different radio shows and TV shows and call-in services afterwards or text-in services afterwards. I mean, these have taken off hugely also, and in terms of adolescence and finding an opportunity for adolescents to be able to ask the questions via text messaging, it's just offering huge opportunities for accurate information when I was out in Malawi recently with another colleague, Kate Lane from the Office of Population and Reproductive Health, we were talking with a local organization there about one of their, text-in programs, and just the amount of accurate information that was being disseminated was huge. And this was for groups of both men and young women that really didn't have access to this information otherwise. So I think as cell phones become more available, and thinking of the gender disparity in terms of cell access for young women versus young men, I think that this is going to continue to be a route that we need to pursue. But I think it's going to be interesting to see how we may be able to do this more, as more young women do obtain cell phones and do obtain access than what is available currently.
Yeah, I guess I would say it's really a changing field. It's something that is evolving, and we need to dig deeper into what are the opportunities. I think context-wise, geographically, there are young women who are getting more access to cell phones, and I don't think we know that much about how they're using them or what the opportunities might be to reach them with information or to offer opportunities for engaging in participation in broader social change processes, becoming connected with other actors, other movements who might be interested in participating in some way. I think we need to know a lot more, so it'd be an area of research, perhaps, of trying to figure out who has cell phones and how are they using them, and what are the opportunities. Just one anecdotal piece of information, when we're looking at women and their access, you mentioned the gender disparity between men and women and their access to the information and to the actual technology. That is so true. Even when women have access to phones, if they're being asked to do something that makes them it may be new to them, they often hand the phone to the guy standing next to them to do that piece of information. So that thing about confidentiality and who has access to the information or their passwords to banking information, those are all very complex things that we still need to work out. But yeah, huge opportunities, I think.
Maybe I'll build on that. I agree with what's been said. I'll mention a couple of specific experiences. So Pathfinder's been growing our mHealth portfolio, as many organizations, a lot in the last few years. And one, we've primarily used mHealth for two main purposes, and they both sort of will tie into married adolescents. And one is around behavior change, so increasing access to information and sort of trying to navigate some of those barriers to services. And one is around actually improving the quality of service delivery through things like counseling algorithms that CHWs can use to counsel young women or for women. So for the behavior change piece, we have a program that we've just finished implementing in Mozambique, focused on young people, youth 15 to 24, and we did two different arms of that program, one for non-parenting youth and one for parenting youth. I will mention that it started as married and unmarried, and what we realized in Mozambique is that marriage is really not what you're talking about, because childbearing happens before marriage, after marriage, in marriage, around marriage, and a different marriage. It's not the division that we see in a place like West Africa. So we realized that the real needs and the different needs for information and services around SRH was with children, without children, for both males and females, 15 to 24. And so we had these two parallel behavior change systems. They're text message based, they're narrative based, so it's like a mini telenovela on your phone, building on behavior change principles, drawing from the telenovela sort of learning, and we tailored them to the specific needs and dynamics that youth with and without children face. So that has been ongoing. We had a dissemination event recently in DC around it. There's a lot of stuff on our website about it, and the Evidence to Action Project is conducting the external evaluation of that. Just finished the evaluation of that, which is why Regina is nodding, because she just got back. And that will be available soon, and I think it has a lot of important lessons for us around your exact question about kind of different cohorts of youth, different populations of youth, and how mHealth can be used to reach them. And just very briefly on the sort of service delivery piece in the use of mHealth is that we've adapted now the CHW algorithm. So it's sort of like a balanced counseling strategy or a strategy for community health workers to counsel women on contraceptive options. We've now adapted those to be sort of youth friendly. So they've included some important key elements that a CHW might want to know about the fact that, for example, adolescents and youth can use long-acting methods so that they're actually appropriately counseled on that. So not married youth yet. I mean, we haven't made that further adaptation, but at least we're trying to think about how to make those existing mHealth tools incorporate the needs of adolescents and youth. So still more learning to do, but we got some things going.
Two questions on the side.
Hi there. My name is Jennifer Parsons. I had a question that is sort of, I guess, outside the box of specific interventions, but from a sort of policy and advocacy standpoint, if there are, within the U.S., what are sort of the levers and entry points that you all see for us as advocates and as advocates to use for U.S. government entities to sort of get them to pay more attention to child marriage and especially, I think, the SRH and violence outcomes that we see associated with those, or associated with child marriage that you've each talked about. I think there's obviously sort of the funding perspective and point of view in terms of USAID, PEPFAR, and State Department budgets. But if there's other places you see where we could be advocating within U.S. government, you know, whatever avenue that may be, from your perspective, what you think those might be.
Maybe we can go ahead and grab that other one while you're up, Sarah.
Thank you. My name is Joseph. I'm from Ethiopia. I would like to thank Tesa for Care Ethiopia, what you did. I know the whole project. My question is, it's not a question, maybe a comment. How do you see the religion and cultural value of in Ethiopia, also maybe in West Africa? Mostly for our local media, there's a problem with challenge. You cannot convince, or you have to convince the religion or elderly, otherwise you cannot move forward. There's a big challenge, as far as I know, in most East Africa, Ethiopia, Eritrea, and maybe in West Africa too. Maybe Kali, you work in an undergoing project also, maybe it's better if you comment on that. That's the biggest challenge in Africa. You have to convince village elders or religious leaders. We try to convince the men in Africa. All religious leaders are men, all the politicians are men, maybe 75% of the teachers are men. So at least we try to convince to care about their daughters. Maybe they don't care about the whole woman, but at least they can care their daughters, you know. So I need your point of view on those religious and cultural elders. Thank you.
Yeah, I'm actually curious beyond if all of you could answer that piece, because I think that you know, these were very different countries or regions or populations within youth, but I think that working with religious leaders across the board is a good question. And then the second question, I don't know if we want to, if we should just go ahead and start with the religious one, and then perhaps then move on to the one about entry points for working with U.S. policymakers. So does anybody in particular want us to start us off with the religious leaders? Maybe Callie, we can move our way down then?
Sure. And I think this is a critical question and a critical point, and one that I think we all spend a long time thinking about and working with. I mean, I think all of Pathfinder's programs and the one I was just referencing have worked very, very closely with religious leaders who and sort of usually through a process of identifying religious leaders who have an inclination to think that this may be appropriate to discuss things like healthy timing and spacing of pregnancy, to discuss things like the role of women, sort of people who may be eligible to be champions of these issues. And you kind of, we start by working with those religious leaders and their associations, and then through them reach other religious leaders with important information about sort of what the different religious texts do and do not say about family planning, reproductive health. We have training curricula around healthy timing and spacing of pregnancy specifically geared to religious leaders in the West African region that were used extensively in Nigeria. So we use these different mechanisms and tools. I mean, I think this is something that all programs work with. and the very design of a program that we do is, to work with local partners who have those existing connections, who know the local communities, who know the right people to tap, who engage those people in the long process of community development. It's not an overnight thing. It's a changing of social norms. It takes years and years and lots of investments. And so I'm not sure I have sort of the perfect answer, but I think there's a lot of different entry points and strategies that we've used in different programs depending on the context. But I think we've done it in almost every project I can think of. It's an important entry point to discuss these issues.
Yeah, just to build on what Callie said, I agree that I think we need to become more systematic in how we are thinking about a social norms process, as a social change process that focuses on norms, which includes community stakeholders with really a big, they have a lot of investment in the cultural values that a community holds. And so I think a change process can't be imposed from the outside. It's got to be led and owned by the people who live in that community. And what we're finding from our work is that a social change approach embedded in local community values starts with key people who have an earnest desire to see change happen and to support them in finding ways to promote public dialogue about those particular issues that are pertinent to that community. So along with the things that Callie mentioned about working with particular individuals who may be more amenable to bringing up those issues in the context where they're working, whether it's religious leaders or other cultural leaders, what we find in making social norms change happen is that a lot of people really believe that they themselves are different from what everybody else thinks, but they're just quietly being, themselves in their own little corner without bringing up those issues with others. And that's true for community leaders or religious leaders as well as the adolescent girls, as the husbands, as everybody else. So bringing up the topics that are often difficult to talk about. So Suzanne brought up the issues of sex and sexuality. Those are difficult things to bring up in public dialogues, but when you do in a safe way, things happen quite quickly. So I would say, part of my personal pet theory is that a social norms approach will be actually faster and more effective than a behavior change approach to some of these issues. And we can do that most effectively with some of the telenovelas or the mass media kind of components that are augmenting our work, working with local activists on the ground. So there's many, many people in those communities who really desire to see that change happen and want support to make those change happen. And, our work is to support them. So maybe that's a long answer.
Yeah, I don't think there's much to add on that point. I agree with both of you. It's the only thing I would say is when you have a religious leader or a powerful leader who gets it, they can be incredibly powerful. I mean, Archbishop Desmond Tutu has been extremely powerful on the issue of child marriage, and that's an incredibly valuable voice. So, where we can raise those voices up, we should. But can I tackle the policy question? Advocacy?
Did you want to add anything to the religious leader one before we go into that?
The only thing I'd really briefly add is that I think religious leaders have been some of the most supportive in terms of HIV prevention, care, and treatment activities. And I think globally and at large, and I think that they're only getting more progressive in terms of support and within the communities to decrease stigma and discrimination against those living with HIV, including adolescents. That's it.
It's all you.
All right. So thank you for asking the question about advocacy. So ICRW, along with CARE and the International Women's Health Coalition, are co-chairs of a consortium called Girls Not Brides. USA, it's a global network, and I would certainly encourage you to, if you haven't already, check them out and participate. What specifically can we ask the administration to do? Congress mandated, as part of the Violence Against Women Act last year, that the U.S. government develop a strategy to end child marriage, and we haven't seen it yet. It's been a year and a half. We hear from USAID that the agency is committed to the issue. They do, as I mentioned, have a wonderful vision for action that's laid out a lot of wonderful things about ending child marriage and meeting the needs of married adolescents. That has not necessarily been translated, as we've heard, into practice across the agency. It hasn't been translated into funding for programs. There has been no across whole of government approach to identifying which programs, which diplomatic strategies, which funding streams will be targeted toward ending child marriage and meeting the needs of married adolescents. So certainly calling on the administration to do what was required by Congress in developing that strategy would be a very important first step. Administrator Shah was at the Girls Summit last week, along with a number of leaders from around the world. He made a commitment in front of that audience and in front of the global community to fund programs with new resources of at least $15 million over the next 2 years to end child marriage. This is not what the USAID press release says, so we're trying to figure out what that means. We'd love to see new resources for ending child marriage come out of USAID. So certainly following up on that is something that we will be doing and encourage others to do. And then one final point, I could go on, but I think we're running out of time.
I have one more question.
Is that the Office of Population and Reproductive Health at USAID is very heavily focused, necessarily so, on family planning, and says that adolescents are cross-cutting. I think as you've heard today, adolescents can't just be cross-cutting. We really need that office to understand the different needs of different cohorts of adolescents, married and unmarried, very young and older, geographically different settings, culturally different settings, and we need that office to pay attention to the comprehensive sexual and reproductive health and rights of adolescents, distinct from family planning, because some adolescents have a need for family planning, not all. Starting with that basic education around fertility awareness, around sexuality education, is a critical need, and one that the U.S. government should be investing in so that you don't only capture adolescents after they're married or after they've had their first pregnancy and then maybe in need of family planning. So, so we are certainly calling on USAID to look comprehensively, to have a rights-based approach to adolescents, to not be scared of saying the words sex and sexuality in their programs, and to not have such a tight focus on family planning.
I do want to build on that and just remind us all that it's that office that's supporting this discussion today where we are going beyond that. We also had a question come up via Twitter, so I did want to make sure that we did loop in our audience that isn't in the room. It's from one of our colleagues from Hijabis, which is a U.S.-based nonprofit working on Muslim women's issues, and the question is, can research studies and findings be adjusted to form collaborative outreach to the U.S. Muslim community? Does anybody have any particular thoughts on that?
Yes.
Go.
That's my answer, yes.
Perhaps how?
Yeah, I mean, I think there's multiple opportunities for collaboration and coordination of learning and lessons, both from research as well as implementation strategies. But I think more specifically on advocacy and kind of coming together on coordinated efforts to improve the information that's available so that our policies are implemented and accessible for everybody, including in the domestic sphere. So, I'd say one opportunity is for collaborating with Girls Not Brides, the group that Suzanne mentioned, which is really about information sharing and coordination as well as influence and advocacy. So it's an opportunity for looking both at some of the domestic issues as well as how they apply internationally, possibly.
We are running out of time. I know that folks will want to come up and ask you specific questions, but one thing we didn't really talk about that maybe I want to talk to you all separately afterwards is how do you envision programming being different for those that are divorced or widowed as a result of HIV/AIDS? I think that there's so many other ways to cut this and so many other subpopulations as well. And so I don't think any of us really had discussed that, but I think that's a whole another
Yeah, thanks for bringing that up. I'd love to just take a quick shot at answering that. The girls in the TESFA program were ever married, so many of them were in current relationships, but many of them were actually divorced or separated or widowed. And it's actually kind of surprising how many adolescent girls are already out of marriage, have been in marriage and are already out of marriage. And they really represent even a more unique and more challenging group to work with, because they are really not supposed to be having, asking for contraceptive information at the health services, so doubly stigmatized. So yeah, definitely an area that we need to do some more work on. And I'll just put a plug in here also for stigma reduction norms work, which is very important in all contexts, but particularly for this population, because they just very, very strong feelings from the community about what their appropriate place is, but it's not really obvious where that is.
Great, thank you. Thank you for pointing that out. I had missed that. So I do want to thank you all actually for joining this discussion, and encourage you to follow us the website that I talked about, the event summaries. We have a blog presence on Facebook and Twitter as well, and I want to ask you to join me in thanking our speakers.